right, welcome. Let's get to chapter 37 straight away and start with going over the overall peripheral vascular disease, which is going to include both arterial and venous. And really, if you get anything from this lecture, make sure you are able to differentiate very clearly between how do we detect, assess, diagnose, treat arterial versus how do we know it's venous, and how do we treat venous, and what are the differences between arterial and venous peripheral disease. A lot of the knowledge that will be here presented is to a degree still, so this lecture should be based or founded upon a few of the other lectures you've received, because especially with PAD or peripheral arterial disease, a major underlying problem is the plaque buildup, which ends up clotting and can form a thrombus, and that thrombus can become an embolus. And you already know a lot of the rest of that story right there. So a lot of what we've covered in previous classes really is the foundation for this problem that we're looking at here. Now, don't be confused and assume that PVD refers to peripheral vein disease. We usually call that venous insufficiency or chronic venous insufficiency. When you hear the word PVD, it really covers, it's a larger umbrella word that covers the artery and the vein as well. So without further ado, let's get right in it. So make sure that the key most important thing is perhaps the first top one right there is for you to be able to differentiate between arterial and venous disease. And also risk factors relating, especially PAD, because peripheral artery disease is one of the most or the biggest problems that we're seeing today in the hospital as well, especially if you have somebody who has who's a smoker, who's diabetic, they have peripheral neuropathy, they don't have sensation in their extremity, and now their blood flow is even limited to that extremity, one or the other or both. And so somebody who has peripheral arterial disease and diabetes and hypertension and hypothyroid, and you get the point, right? Or who's had an MI in the past, or who's had a stent in the past. These are all the typical classical patients that are very highly at risk for PAD. So make sure you understand the risk factors for these people. Also, we want to know what the clinical manifestations for both of them, PAD and the venous, but mostly focused on PAD. And then what do we do as nurses? What do we need to know too? So really, in a nutshell, it's quite straightforward what we're going to be covering here. So peripheral vascular disease is, as we know, it's a disease in the blood vessel in the periphery, right? It just means that the same thing that's happening in the coronary artery, or that might be happening in other areas of the body within the arterial system, there is basically a disease that's starting to happen, the whole plaque buildup, right, underlying the problem of coronary artery disease and myocardial infarction and ischemic stroke. Except in this time, what we're looking at is this vascular problem, this arterial problem is happening in the periphery. So just keep that in mind. It's happening outside of your heart, outside of your brain, but really from a pathophysiological standpoint, that narrowing, that blocking, that spasm is no different no matter where it's happening, except right now in this lecture we're focusing on the peripheral diseases. And you know, some people use the word PVD interchangeably with PAD, but we really shouldn't. Peripheral vascular disease is just again a large umbrella term that could cover vein problem, venous insufficiency, or arterial. So when you do refer to an artery disease, specifically an artery disease, don't use the word peripheral vascular disease. Use the word peripheral arterial disease if we know that that's what the patient has, okay? They're not the same. One is just a larger umbrella. And this large umbrella term is really referring to a disease or damage that's happening to the blood vessel other than the heart or the brain, again, in the periphery. And it can be known by several names, but when we know it's arterial in nature, then we don't want to call it peripheral vascular, which is the umbrella term. We want to specify what we know, because it makes a big difference. So which is most common, right? Arterial or venous? And this is where we have to pay a little bit of attention. I just added this slide in a few minutes ago because I think it wasn't very clear as to which is more common. And really what it depends on, well, there's two that are most common, and you need to understand the distinguish between these. Peripheral arterial disease is the most common form of peripheral vascular disease around, period. So when you speak peripheral vascular disease, the most common problem that we see is arterial. That said, when a lot of the leg ulcers start to form, right, we need to understand that the most common reason or underlying cause of leg ulcers forming is ultimately chronic venous insufficiency. And there can clearly be an overlap between arterial and venous at the same time. So a lot of the same patients that you see that have hypertension, the metabolic syndrome X patient with that sort of adipose tissue buildup, slightly obese, they smoke, they don't eat well, they have diabetes, they have hyperlipidemia. And so these are the patients that will end up having peripheral arterial disease, but it's not uncommon for them to have chronic venous insufficiency as well. And end up having leg ulcers. So just keep that in mind. So in terms of leg ulcers, most people with chronic venous insufficiency, that's the most common cause. But overall, for peripheral vascular disease, the arterial problem is the most common. Now, again, which is worse of these two? And remember that peripheral vascular disease is just a broad term that's used really to describe diseases of the blood vessels outside of the brain, outside of the heart. And so PAD, or peripheral arterial disease, is again, I'm just repeating myself, a subcategory underlying peripheral vascular disease. And it's really, again, referring to atherosclerotic plaque buildup in the arterial walls, which ends up to occluding of the lumen of the artery, and that leads to changes in the blood flow, right, in the normal blood flow. Now with vein or venous disease, right, and the peripheral arterial disease, they're both conditions that can cause poor circulation in the leg and the feet. And what that ends up resulting in is limited limited blood flow. The blood flow is going to be abnormal. And then the limbs start to become deprived of oxygen and nutrients. This sort of ischemia starts to kick in, which end up causing the area to become inflamed, and open wounds and ulcers can start to form. All in all, peripheral arterial disease is quite common. There's 8.5 million, in fact, some people claim significantly more, and 1 in every 5 person age 60 and older could end up having or do have peripheral arterial disease. Now, we need to really think that really one of the reasons why this happens is because we need to understand that atherosclerotic plaque buildup in the artery is very common in a lot of people because we have lifestyle, because of, yes, maybe inherited or genetic, small amount of it, but remember epigenetics, we had that talk. A lot of the lifestyles that we're leading are stressful. We drink lots of coffee, like I personally do, which is not necessarily that good. And we smoke, and then we eat a lot of the processed foods. We eat a lot of the fast foods. We don't exercise. We have stressful lives as nursing students. You can imagine what that's like. And so if left untreated, then peripheral arterial disease ultimately will lead to gangrene, limb amputation, heart attack, and stroke. And I will forewarn you, there is a couple of images at the end of this lecture that might be gory by some norms, but we are nurses, and so we should be able to be exposed to this, such as an amputation and what that looks like, for example. So these are very classic patients that we really want to talk about upstream medicine, lifestyle, and whatnot. There are 4 stages of peripheral arterial disease. You can imagine which is the last one of all of them. Stage 4 is where necrosis and gangrene kicks in, and that means death of the tissue. By that point, it's probably impossible to turn around, and they may need to have an amputation. And so stage 1 is where it's asymptomatic. You may or may not find a bruit, some type of aneurysm on the physical exam. Stage 2 is where claudication starts to happen. They start limping, it hurts, right? Reproducible muscle pain with exercise, so pain happens with exercise. Stage 3, pain is happening with rest, right? When they wake up in the morning, dependent position relieves it. And that's going to be very key for you guys to pay attention to as we move forward. This is a very important slide that you just need to learn. You just need to memorize. You just need to be able to distinguish between both of these. So when you look at arterial, really there's not going to be that much edema, as opposed to venous. There will be lower leg edema. Intermittent claudication, pain, right? It happens mostly with the arterial. The venous will have pain. It's dull, it's achy. So pain is not necessarily the best way to distinguish them. Edema is a good way to distinguish them. Arterial is going to end up having no pulse or very weak pulse, but there will be no drainage, versus the venous is going to have a present pulse, but there will be drainage. So that's a really big difference right there. The wounds that are arterial tend to be round and smooth. They're more like sores. The venous are going to be irregular borders, and when you talk about arterial, it'll end up being black eschar, and notice where it's black, it's usually in the toes. Toes and feet is usually where arterial, whereas a key thing that NCLEX likes to ask you is a lot of the venous problems tend to happen not so much in the foot or in the toes, although it can, but generally speaking, that's going to be more arterial. With venous, you want to just simply memorize ankles and ankles, okay? So come back to this image, print it out, memorize it, chew on upon it, put it under your pillow, whatever helps you learn this image, because you will be asked a lot about to understand, to see if you know the differentiation between one another. So leg ulcers or venous leg ulcers usually are due to overall sustained hypertension, mostly venous hypertension, and again, that's going to result from chronic venous insufficiency. And what you kind of want to understand is the normal venous system, that the pressures decreases with exercise as a result of the action of that calf pump, the muscle pump, there's really, if you want to think about it this way, there's two main ulcers that are going to affect the lower extremity, right? Since this slide is focusing on ulcers, and there's arterial oral ulcers. And of course, these occur where? Well, in the arteries, and they carry oxygen, nutrient-rich blood from the heart to the body and the tissues. Now, venous ulcers, remember, these are going to be more common, and the high majority of these ulcers are venous ulcers to the lower limb of the lower extremity. And they develop in the veins that are supposed to be bringing back the blood, the blue blood, the unoxygenated blood, back to the heart from the tissues that have already been given and the oxygen and the nutrients from the arterial blood. And so one thing that I think is key to remember here is that how does blood get back to the heart going back up? When the heart pumps it forward, it pumps it it creates the pressure through that pumping that the body ends up getting it as perfusion with oxygen and nutrients. Now, for blood to return to the heart, we have to remember, why do we use SCDs or compression devices? Well, we want to create a little bit of pressure in that leg to help the leg. So the leg has a series of valves, and it is these valves that allow blood to pump back up. And so when we ask patients post-surgically to use SCDs or to get up and ambulate, we're encouraging them to ambulate to get some strength to that muscle so that the valves don't lose strength and are able to pump blood up a little bit, and then the valve closes and it pulls there for a little bit, and then it pumps it up to the next valve and it closes, and then it just keeps pumping it up until it gets back to the heart. So you can imagine with venous insufficiency, it's in a sense, it's a major valve problem that we're going to be looking at very, very carefully. And I put this in so that you can look at the image on the right where the blue blood is supposed to be returning, and look at the normal venous return. Blood flow is perfect. There's 3 valves there. First valve opens up, closes, then it pumps it up to the second valve and it closes, and it pumps it up to the third. But look at where venous insufficiency is happening. Those valves are no longer able to fully close. So it's really an inadequate return of venous blood from the legs back to the heart. And so some of the clinical symptoms, they get tired, they get heavy, achy, cramping in the legs. And this is a key thing. Pain is going to worsen when standing, and it'll improve with leg elevation, and with leg elevation. With activity, it might decrease, but what you want to understand is with venous, you want to lift the leg to improve the problem. Now, if you look at the arterial problem, remember PAD is all about plaque buildup, narrowing. It's no different from an MI, no different from a ischemic stroke. It's the thrombus building up ultimately, and so there's a narrowing of the arteries. Can happen in the pelvis, in the legs, can happen in many different parts of the body. Symptoms with this, again, cramping, so that you can't really differentiate, but there's pain. The tired legs, hip muscles, kind of similar, but with clinical indication, pain is going to worsen during walking and activity, as opposed to the venous, pain improves with activity. So if they are walking around and they feel their pain is improving, you should be able to, at this point, understand that it's more of a venous insufficiency. Peripheral vein problem, not an artery problem. And with peripheral arterial disease, it'll subside with rest. Okay, so those are two key things that I want you to pay attention. So this is just an image that I showed you where patients that have peripheral arterial disease end up having a lot of the ischemia build up. And so you can see the feet, one of them is reddish. You can see the toes, they're starting to be gangrenous, dark, eschar buildup. Remember, that's artery. Below the feet, sometimes that can happen as a problem. Those are arterial ulcers, usually at the heel or the top of the toe. Gangrene is arterial. So remember to keep this in mind. One thing that I think this slide is important for you to keep in mind is where it says loss of hair over the dorsum of the toes, that shiny look, right? So that shiny look that you can see in the image of the feet, of the toes, up in the top left is classical representation or manifestation, clinical manifestation or sign or symptom of peripheral arterial disease. I threw this in there so that you could get a good image of mostly what varicose veins and bulging veins, which we're not going to go that much into right now. But look at the chronic venous insufficiency, CVI. Swollen leg, the texture of the skin is not so much at the lower extremities. Notice how all the way at the far right, it's happening already at the ankle, and it's moving. The image right below it where it says skin color and texture changes slightly above the ankle. These are classic signs and symptoms of chronic venous insufficiency. I also want you to make sure that you learn this very, very careful, because being able to understand what a peripheral arterial disease is extremely important. So you need to know that the type of pain, or the 6 P's, pain, pallor, pulselessness, poikilothermia, which is just cool to touch, and palpation. Palpate bilaterally with the back of your hand when you do your assessment. Don't palpate with your own hand. Paresthesia and paralysis, right, or immobility, the inability to move. So all of these 6 P's are clinical manifestations of peripheral arterial disease. So they will have intermittent claudication. They will have pallor, pale, cool extremity. They may have pulselessness as opposed to venous, which will have a pulse, popliteal, dorsalis, pedis, behind the tibial, pulse tibial. Use the tip of the fingers. Do not use the thumb, because thumb has its own pulse, and do it bilaterally simultaneously so that you can compare. If one leg is hot and one leg is cold, how are you going to know which one is hot or cold unless you use the back of your hand to touch the feet simultaneously? Cold temperature is also pretty normal with a lot of the PADs. Numbness and tingling, that also is hard to distinguish, especially with the diabetics who have peripheral neuropathy or people who have B12 deficiency. And paralysis is when it just hurts so much, or they're unable to move that extremity, and that usually is a late sign. That paralysis tends to go in with a lot of the necrotic eschar starting to build up. So these you need to know that. This is what I would highly suggest that you do for this main lecture is print this out, take a photo of it, print it, copy it, create your own on a Word document, whatever you want to do. Make sure you're able to fill this out on your own, right? Because this will help you tremendously to be able to answer the questions that I am going to be personally asking you. And then again, remember with this filling out, go back to that image, that chart, because that'll give you the information you need to know. So with PAD, peripheral arterial disease, remember it's strongly related to cardiovascular disease, CVD, or coronary artery disease. and their risk factors. So when you think PAD, if you can remember risk factors for coronary artery disease, for cardiovascular disease, patients who have MI or who are at risk for MI, it's the same risk factors. So basically, patients that with peripheral arterial disease are going to have significantly higher risk of mortality in general, right? Cardiovascular mortality and major coronary artery events, including stroke. And so peripheral arterial disease is a marker of really advanced overall systemic atherosclerosis, and it's just happening in the periphery. So keep that in mind. That's key and very important to know. And we'll go. Well, I do have a slide with the risks shortly. So common sites of where this atherosclerosis could build up, really pretty much anywhere. Abdominal aorta, the iliac area, all the way down to the femoral area, the popliteal area, all the way down to the lower extremities, right? And so you can imagine how with atherosclerosis lesions or atherosclerotic plaque buildup, there will be the slowly disappearing pulse in one of the extremities or both of the extremities. So that's classic peripheral arterial disease. So here's a slide with the risk factors. It typically is going to appear usually when they're 60 or above, but it can happen to a lot of people. Atherosclerosis is already happening with people who are in their teens, and even in their 20s. Usually it's largely undiagnosed. And remember, in one of the slides previously, 77% of the people already have atherosclerotic buildup before any sign or symptoms start to manifest. And so what are the risk factors? Well, it's right there. Obviously, nicotine, which we know is a vasoconstrictor, tobacco smoke is going to impair cellular oxygenation, and it's going to increase blood viscosity. It's going to increase homocysteine levels. We know that those are all risks that lead to a lot of the cardiovascular, coronary artery, myocardial infarction, stroke problems. Other risk factors from a lab perspective, apart from just homocysteine, I probably should have added homocysteine onto this chart, so I do apologize, but it could be elevated C-reactive protein or CRP, family history, hypertriglyceridemia, increasing age, and obesity, sedentary lifestyle, stress. You get it. But obviously tobacco use, chronic kidney disease, people with diabetes, hypertension, and the lipids, the lipid problems. Low dense lipids, apotype A, B. And so further risk factors for PAD, I created a second slide here so that it was a little bit more specific. I'm glad I did create this slide here. High homocysteine is just a big risk, but being African American, being black is a higher risk. That tends to be, again, in many of the cases that we're seeing, because they happen to live in a lot of the areas in the zip codes where there's poor nutrition and there's not that much access to the good nutrients and good nutrition. So it is linked to zip code, unfortunately. And so as we move forward in our upstream sort of healthcare approaches, a lot of the approaches that we're going to be looking at really are public health. And how can we bring better food to inner cities? How can we bring better food, not only for Black or African American, but for anybody who lives in the city, Hispanic, some of the Caucasians, and anybody who is struggling with unemployment, struggling with homelessness. These are populations that are just really at large disadvantage, and we need to create systemic structural changes from a public health perspective to benefit these patients, because they deserve it. They're no different than anybody else. And obviously those who have money, then they're privileged because they can buy vitamins and they can have access to better foods. And so really just that idea that everybody is equal, it just doesn't fly anymore. Because we know it's untrue. We know it's not true. Those who are born into families who are privileged and have more money just are going to have better health, period. So those patients are a lot of times the patients we're going to be seeing with gangrenous feet, with diabetes, with cholesterol problems, and on top of that, they're already stressed out. If they're homeless, then now try to tell them that, the only way that they can, or one of the ways that they treat with their stress is by smoking or drinking alcohol because it keeps them warm in the cold night, or You go figure, but we do have to have that conversation with them. Obviously, age, as I talked previously, obesity is a big problem. Family history, it plays a small percentage. But if they've had strokes or heart attack or coronary artery disease in their family, yes, they're going to be more at risk. But remember, epigenetics says that with proper lifestyle changes. So don't go down the track when you educate your patients to tell them that, oh, if you have it in your family, then well, there's not much we can do. We know that is absolutely not true. There is a lot that they can do. Now, so with homocysteine, really, what you really want to understand, how can we naturally reduce homocysteine? Well, we know that B6, B12, and folate. If you learn nothing else with homocysteine, those three, B6, B12, and folate. So increase folate in your diet, increase B6 and B12. We know all of these three things can help decrease homocysteine. They help the heart function properly. And in high folate especially will increase to improve blood flow to the veins and the arteries, which is really important. Unfortunately for people like me who, I have to admit, my name is Jeremy and I am a caffeine addict. Really zero coffee or zero tobacco for this type of patient or patients who already have. I actually did my homocysteine levels and at one point they were like 18. They're supposed to be below a 10. And so so I went back again after about half a year of not drinking coffee, and boy, they just went back down really, really, really low. I mean, I did add B6 and B12 because I was very concerned, and folate. And so I went back and I was like at 4 or 5 homocysteine level. So I do drink a lot of coffee. I just make sure that I add B6, B12, and folate into my diet. So really, it is there are some studies that show that reducing animal proteins, foods of animal, can help reduce that. And a lot of times in vegans, if they don't eat properly, now you can be vegan or an elderly person, they have high homocysteines. You can be an elderly person, you can be a vegan and really bring your homocysteines level down. You can even eat animal products, but you have to be a little bit more careful because animal products will shoot your homocysteine levels up. So bottom line, with this slide and with homocysteine specifically, we can control it without chemical medications through food, through dietary supplements, through just make sure that when you do the B6 and the B12, use the active form of like folate, like L-methylfolate, which we know can achieve plasma folate levels of up to 700% higher than any of the synthetic folate. Also make sure that you use the P5P version of the B6, or when you talk to your patients, they use the active form of the B6, not the synthetic. That's going to make a big difference. And then there's other things like omega-3s, fatty acids that have EPA and DHA, because they're triggers against inflammation. So we know that that's all very good. So that said, I just threw in a slide here to show you this is one of hundreds or thousands of researches out there. Use PubMed, go and look at it. Now we know that B12, folate, and B6 are the main determinants of homocystinemia. So make sure we're getting it in our diet. I'm throwing some names in here. Dr. McCulley with Engelbleek back in, I think in France, in a university, they funded a research which started off as mainly for malnutrition, and they found out that sulfur plays a major role, together with the nitrogen in metabolism. So sulfur deficiency is also playing a big role. So eat sulfur-rich foods, right? Onions, garlic, and so on and so forth. I just wanted to bring that in so you could see. Stephanie Seneff really has done tremendous research. I'd highly recommend you looking at her on YouTube. She's done great. She also is one of the key persons I believe in MIT, I could be wrong, don't quote me on that, who is looking at glyphosate as a major toxin, which a lot of the big agro industry is putting forward, and that's creating tremendous havoc in people's health. So as healthcare professionals, I think it's really good to be informed and to look into that. So let's look at the description. Again, this is just, where can peripheral arterial disease happen, right? Remember, peripheral arterial disease is all about atherosclerosis. And please, if you didn't get this from any of the previous lectures that I talked about, do not be confused to think that plaque is the problem. Do not be confused to think that your high lipids is the problem, right? Because then obviously then the surgery is the only solution, then a drug is the only solution. We need to start remembering that plaque is building up because the endothelial arteries don't have the L-arginine, don't have the proper nutrients, don't have, and so they're weak arteries. And these weak arteries, once there start to be microvascular ruptures, then it's only normal for the body to start building plaque. So plaque is not the enemy, people. Plaque is the body's natural response mechanism to an already weakened blood vessel. So we need to understand that plaque is not the problem. But that said, plaque will build up in the iliac artery, in the femoral artery, in the popliteal artery, in the tibial artery, in the perineal artery. And in advanced peripheral arterial disease, multiple levels of occlusions are going to be found. And so at some point, if they're in stage 4, yes, we will get to have, remove a plaque in wherever it is located. We may end up having to do amputation. So these are the patients that you're going to see in the downstream acute care, critical care setting. Classic sign and symptom of peripheral arterial disease is intermittent claudication, right? And boy, if you can't remember this from the previous lecture that we had, remember ischemic pain is happening because of a buildup of a lot of those metabolic byproducts that are happening in the body, such as, remember, when people end up having sepsis, what is that lab that we send out on ice? It's lactic acidosis, and it comes from that anaerobic metabolism. The body is not getting enough oxygenation, people. That's the problem. So once the patient really stops exercising, that lactic acid is cleared and the pain is going to subside, which is why with peripheral arterial disease, resting helps that lactic acid sort of go away. And so remember, the intermittent claudication is ischemic muscle pain caused by constant level of exercise. If you stop the exercise, it'll disappear, and it can be reproducible again. And not everybody will have intermittent claudication that has POD, but 1/3 to maybe half of the patients with POD will show classic claudication symptoms. And so remember, I guess what I should be saying that the rest of them, if they don't have that intermittent claudication that I just mentioned, will have either no symptoms or they'll have atypical burning, heaviness, pressure, soreness, tightness, weakness. They'll describe it in different areas, right? Foot, in the hamstring, in the hip, the knee, and the shin. So keep that in mind. All right. Paresthesia, we talked about that usually is going to happen from what? What does it happen from? Nerve tissue ischemia. So if blood is not getting down there, blood carries nutrients and oxygen, then the nerves aren't going to be getting that perfusion that they need to get. And so paresthesia is normal with or without diabetic neuropathy. But if they have diabetic neuropathy on top of it, then go figure. Their paresthesia could be a combination of the fact that they have diabetes and clearly the fact that they're not getting enough perfusion down to the area that they want with the lower extremity. And so we'll talk about diabetic neuropathy, I think, next semester when we go over diabetes. And so the neuropathy really is going to represent, because it's a nerve, more as a shooting, burning pain to the extremity. So keep that in mind as well. All right, let's move forward. Again, the thin, shiny, taut skin tends to be a sign and symptom of that. The peripheral arterial, loss of hair on the lower extremities, diminished or absent pedal, popliteal, femoral pulses, pallor of the foot with the leg elevation, reactive hyperemia of the foot with dependent position. So pallor is just the blanching of the foot, right? And it's going to develop in response to leg elevation. So remember, hyperemia, which is just redness of the foot, develops when the limb is in a dependent position. So when they start having redness when their foot is down, then that's a good sign or manifestation of peripheral arterial disease, okay? Pain at rest. So remember, as peripheral arterial disease progresses and multiple arterial area or multiple areas of the arteries are starting to get clogged up, blocked up, plaque is building up, continuous pain develops at rest, right? So rest pain is going to most often occur in the foot or in the toes, and it's going to be aggravated by limb elevation. Shall I repeat that? Aggravated by limb elevation. Pain is aggravated by limb elevation. The venous, you want to elevate the leg. With this one, the pain is going to be aggravated, right? Likewise, that pallor will happen when the leg is elevated. Patients often are going to try to achieve pain relief by dangling their leg over the side of the bed or sleeping in a chair to help that gravity, to maximize that blood flow. They want that blood flow because it's a blockage. There's not enough getting to the toe. They want to keep their legs down to help that blood flow as well. So not everybody has to have that leg elevated. So keep that in mind. Be very careful. So what do you think between these three things? Is it arterial or is it venous? So you have a patient, feet are pale, they're cool to touch, they have diminished pedal and posterior tibial pulses, decreased sensation, right? Paresthesia, for example. The patient has a small open area, the lateral side of his left ankle. So what are your concerns with this type of patient, right? So don't always be fooled. We remember ankle, generally you want to think venous, but that doesn't always have to be. So I don't like the ankle as the main thing to determine whether it's arterial or venous. The pulses, the type of pain, and whether it should be elevated or decreased are going to be the three key areas for you to look at. And so in this case, because of the pale, cool, decreased sensation, lack of pulses, people. So even if I throw in an ankle at you, don't jump with the ankle automatically to venous. Go with your other assessments first, right? So this should be bringing to your mind that it's a complication or that it's evidence of what? Arterial or ulcer? Arterial. Arterial, 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 okay? All right. So critical limb ischemia, or CLI, patients who have peripheral arterial disease that have diabetes, heart failure, history of a stroke, are going to be at increased risk for critical limb ischemia. It just makes sense. If you understand what peripheral arterial disease is, if you understand the risk factors for coronary artery disease, if you understand the risk factors for coronary vascular disease, they're all the same, people. It's all happening in the artery, except in this case, it's happening in the periphery. And so if it happens long enough and you happen to be diabetic and you happen to have a history of MI in your family, history of stroke in your family, or you've had a previous stroke, or you've had a previous MI, or angina, these are all patients that are going to be really at risk for having CLI, or critical limb ischemia. And it's going to be pain that, rest pain lasting for more than 2 weeks. It just won't go away. And even maybe some of the arterial leg ulcers or gangrene is going to happen as well. They may or may not have venous, but all right. So complications so remember, with arterial ulcers, right, which are ischemic in nature, most often occur over bony prominences on the toes, feet, and in the lower legs. And I believe if you go to chapter 37, there's a slide or a table in there that goes over this. So I would highly suggest that you look at that. And some of the complications are atrophy of the skin and underlying muscles, delayed healing, wound infection, tissue necrosis, arterial ulcers as well. Okay, further complications. If peripheral arterial disease is going to be present, right, for an extended or a long or chronic period of time, collateral circulation may end up preventing gangrene to the extremity. So uncontrolled pain and severe spreading infection are going to be indicators that maybe ultimately an amputation is going to be needed in your patients who may not be candidate for revascularization. If they're candidates for revascularization, they'll go into a cardiovascular thoracic surgeon or may go into try to reperfuse the area, revasculate, try to put a stent in, put a balloon. Somehow they're going to try to open that up. And it's no different from putting a stent in the heart, except that they're doing it down to the lower extremities. And you'll see, I have a slide that I added some images that'll help you understand that. So that's important to understand, is that we need to try to catch it earlier. Now, a lot of people call this BPI or brachial pressure index. Really, it should be ankle brachial pressure index or ABPI. Some people in the hospital refer to it as the brachial pressure index. I like ankle brachial because that's really what we're doing at. And this is so. So how do we test for peripheral arterial disease? Well, voila, here you have it. Ankle brachial pressure index is one way to assess for this. And thankfully, PAD is really fairly easy to diagnose, just simply using this peripheral arterial measurement or disease that we call ankle brachial pressure index. It's a non-invasive test. It's really simple to do. What you really need to know right now, I'm not going to go into numbers, you'll get that in third semester. We're going to strap a blood pressure cuff onto your arm and one onto your ankle. And if the blood pressure in your ankle is lower than it is in your arm, there's a high likelihood or a pretty good chance that that patient is going to have some problems with blood flow to their legs, to their extremity. And that is a sign of peripheral or vascular disease, or to be specific, peripheral arterial disease. Now, the ABPI test is only one way of looking at heart disease test and peripheral arterial and plaque buildup, because there are other things such as an ultrasound of the blood vessel, a treadmill test. They could do an MRI angiogram. They could do a computerized tomography or CT angiography, right? And so those are all other ways of testing them. But I want you to know that this is a very simple one to do. We should know that a normal ABI is 0.9 to 1.3, right? That's an adequate blood pressure in the extremities. Once they go between lower than 0.9, let's say their arterial brachial pressure index differential is 0.7 to 0.9, that's a mild peripheral arterial disease. Once that pressure differentiation goes down to 0.4 to 0.7, that's a moderate. And once that pressure index is less than 0.4, that is severe peripheral arterial disease. And so we'll end up doing this first. And if they're 0.9 to 1.3, great, not a problem. The likelihood of getting angiography and MR or CT is very, very low. But once they start getting into that moderate or severe, the doctors may start ordering further tests like that MR or CT angiography. All right, so here you have it, Doppler brachial pressure or ABI, which we can use, or angiography. So again, these are just some of the tools or diagnostic studies that we can do after we can detect if there's an actual PAD with that ankle brachial pressure index. So for what do we need to know for risk factor modification? Well, if you know that their homocysteine is high, if it's checked, usually that's not always done in acute care settings or critical care settings, but in outpatient settings it is. We'll try to decrease that. And we talked a little bit about how we can do that. There are natural ways to do it. Obviously, stop smoking. If they have diabetes, their hemoglobin A1C would hopefully be below 7. We really would like to be at a 4.5 or 5.0, 5.5. That's the ideal world, but a lot of patients, that's very difficult to get, especially if their lifestyle is not changing. Aggressive treatment of hyperlipidemia, yeah, that generally means start them on a statin. But there are more professional panels that are starting to come out that are looking at the size of the lipoproteins as opposed to the number, and that's a little bit more important. So watch out with just assuming that high LDL is at this point necessary for treatment. Again, that's for the doctors to determine. Try to keep their blood pressure low. Hypertension a lot of times happens in patients who have a lot of toxins build up in their body. In fact, most of us, if you use makeup, if you eat vegetables that are not organic, that are coming from major agro farms, there's probably pesticides on them. If you breathe the air in the environment, if you buy sheets or furniture, if you bought a new home, the paint on the walls, I mean, you can imagine the amount of toxins that our body are being exposed to. So trying to lower those toxins in one way is really, really important. as well. And they may need to be going on some ACE inhibitor or metformin for a diabetic, and so on and so forth. With hypertensive patients, the DASH diet, we know, again, is very good to try to reduce it as well. So further, and so here you have it. These are a few of the drugs we use, ACE inhibitors to, for these reasons right here, as that you can see. Helps the patient with cardiovascular morbidity and decreases mortality. And so we should be giving drugs really to patients when they are working with their lifestyle. They need to be informed that the drug can really help them, but unless the underlying reason for which they're having all of these CVD, CAD, MI, stroke, atherosclerotic plaque buildup risk factors that lead to that, like smoking or eating processed foods or drinking high fructose corn syrup, these conversations we just need to have with the patient. Antiplatelet agents, aspirin, Plavix, are important to give because they can reduce a lot of the risks that they're at. Remember that if you use other of the natural, remember we have to tell them to watch out with the ginger, watch out with the garlic, watch out with the ginkgo, watch out with the fish oil, watch out with the EPA and the DHA because it can put them at risk for bleeding. Well, if they happen to not be on one of these medications, we can tell them that if they consume ginger, garlic, ginkgo, fish oil with the EPA and the DHA, omega-3s, for example, which are not only anti-inflammatory, but they're blood thinners, it can help them tremendously with a lot of the problems that they're having, that atherosclerotic buildup. The one thing with this I want you to be careful is watch out with the Pledol or God, I hate to pronounce it, silostazol drug that is right there because it's contraindicated with heart failure patients of any severity. So you do need to know that silostazol do not give for if they have heart failure and they're having peripheral arterial disease, they should not get it. If they have peripheral arterial disease or intermittent claudication, which is a sign of the peripheral arterial disease, and they don't have heart failure, you can give them that medication. So if the doctor happens to order for it and you know this patient has a history of heart failure, call the doc up and say, hey doc, I noticed that the patient has silostazol or Pledol ordered. I just found out when I was talking to the patient, he or she has heart failure. Do you want to maybe change it for Trentol or some other medication as opposed to that because it's contraindicated? Big no-no. That's a big thing to learn from that slide. Exercise therapy is really important. If they can get a supervised exercise program, really that's what's recommended as an initial treatment for all patients that have intermittent claudication, because a trained professional will guide them through. Exercise should be really 30 to 45 minutes per day, at least 3 times a week. And I think the general surgeon, one day they asked him, they said, isn't that a little bit, he said, well, ideally we really want 5, but we feel that if we tell them that they should be doing that 5 days a week, they will never start. So we lowered it to 3 days a week. So we really should be telling our patients 5 days a week if they can manage to do that. And then for a minimum of at least 3 months. Now, although walking is most commonly given as a prescription exercise for PAD, peripheral arterial patients, there are other ways of exercising, like cycling, for example, that can help improve walking ability and the quality of life overall with patients that have peripheral arterial disease. And really, we know, bottom line with this slide, we know that patients that have all that atherosclerotic buildup, which we are calling peripheral arterial disease, really, if they exercise on a daily basis, they have much, much better quality of life and higher survival rates, period. Again, try to keep that BMI below 25. And remember, when we talk about diet, is fat or fats good or bad? What do we have to distinguish between fat and fats, right? When we talk about BMI, we're talking about adipose tissue, the fat in the adipose tissue. That doesn't necessarily mean avocado and nuts are necessarily bad for the individual. And so, yes, we may want to limit some of their fats depending on their genetics. And we had that lecture previously so hopefully you watched that. But when we're talking about keeping the BMI below, we're talking about adipose tissue. That's the fat that really, if it starts to build up more than it should, is really putting the patient at risk. So really, even a modest or sustained weight loss of, God, 3 to 5%, they believe, can really help triglycerides, A1C, or if their A1C is normal, can help them from developing type 2 diabetes in the first place. So really, weight loss is absolutely important. And so keep that in mind when we do our patient education, especially. So in terms of assessment, yeah, we want to assess for diabetes type 2, especially. Do you smoke? Do you have hypertension? Do you have hyperlipidemia? Are you obese? Is your BMI? So we talk to them about their BMI. Talk to them about the importance of trying to lower that amount of adipose tissue, which is really ultimately we expect that BMI will help prevent them. So really, this slide here is saying, does your patient have that syndrome? Does anybody remember what that syndrome is called? If they have 3 or more of 5 of, and a lot of your patients have 5 of those risk factors. Well, metabolic syndrome X or metabolic syndrome, that's when they have 3 or more of those. You've seen it before, you've had it before, you will hear a lot more next semester about metabolic syndrome X, believe me. Further assessments, their exercise intolerance, do they have loss of hair and shyness on their leg? You should be getting that by this point. Decreased or absent peripheral or pulse. At this point, we may need to use the Dopplers. If they're using a Doppler, it's probably not venous. Although if they have PAD, they are diabetic, it doesn't mean they may not have chronic venous insufficiency. But generally speaking, decreased or absent peripheral pulse is really arterial, it's atherosclerotic, and intermittent claudication. If they have it, good sign that it's PAD. What is the nursing diagnosis for these patients? Well, you can imagine. What is peripheral arterial disease? Well, it's an atherosclerotic plaque buildup. It's the same risk factors for anybody who has CVD or CAD, MI, stroke, risk factors. And so we know that if there is a blockage, if there is a thrombus, if there is plaque buildup, then there's not going to be enough peripheral tissue. So decreased perfusion or ineffective peripheral tissue perfusion, so lack of oxygenation, the inability to ambulate properly, activity intolerance. Just like a heart failure patient may have activity intolerance, they will as well. Same reason underlying that plaque buildup, right? Chronic pain, ineffective health management, and a lot of that is just related to lack of knowledge of disease or lack of knowledge of self-care measures. So if a patient has ineffective health management due to or secondary to or related to a lack of knowledge of their disease or a lack of self-care measures, well, guess whose job and responsibility it's going to be to talk to them about what knowledge about their disease they should have and what their self-care measures they should be taking care of? Us. And you can now tell them about CRP. You can now, after this slide, talk to them about homocysteine. Encourage them to get their doctor to measure their homocysteine. If your primary care doctor is not measuring homocysteine, ask for it, right? And if they tell you why, tell the patient to print out why homocysteine is a risk factor. It is clearly a risk factor. And so we will tell them about tobacco. We'll tell them about high fructose corn syrup. We'll tell them about aspartame. Get rid of that toxin. No, right? And then at the end of the slide, I got one thing that I really want to throw in that I think is very important to what we can tell and educate our patients on. So in terms of planning, we want to try to have the goal to get them to have more perfusion. So the pulse will come back. The coolness will be restored by warmth. The relief of pain is happening. They used to walk only from here to the door. Now they're able to walk to the front door of the house, right? That's an improvement. That's a goal that we want to try to get. So you must remember that when we have planned for our patients and we are creating plans, we must always assess for the baseline, right? So if you don't ask, well, what were you able to do before a lot of this happened? They say, well, I walked around the block now once. Then you say, well, where are you at right now? I can hardly get to the door. Well, we should hopefully try to get them back to walk around the block once. But before we get to telling them, well, let's try to target and shoot to walk around the block once. Well, if you can only make it to the door, which door? The door of your bedroom. Okay, well, now we want to try to make it to the door of the kitchen or to the front door of the house. Or now now our goal is going to try to get the patient to be able to walk out to collect the mail and come back in the house. So really it's a step-by-step type thing. Now with their skin, we want to make sure it's intact. There's no open wounds. Skin is intact and the extremities aren't showing any complications like redness or pallor or decreased pulses. And then just try to increase their knowledge of the disease and treatment plan. So people, if I ask you what is peripheral arterial disease and you tell me that it's an atherosclerotic plaque buildup problem, that is the same reason that if you do not tell your patient who's going home after having some form of surgery or perhaps even an amputation of a toe because of peripheral arterial disease, if you do not tell them that that problem that they're having is no different than somebody who had an MI or somebody who had a stroke or somebody who needs to get coronary artery bypass graft or somebody who needs to get a stent, right? If you're not telling your patient that, you're not doing your job. So increasing knowledge of their disease is telling them that they have the same disease that is putting them at risk for myocardial infarction and a stroke. So underlying PAD is CAD, which is called coronary artery disease, or CVD, cardiovascular disease. And we know without a shadow of a doubt that lifestyle, stress, diet, oxygenation, getting out barefoot on the ground, eating proper foods, eating superfoods is extremely important. So we do need to be able to have that conversation with our patient. Health promotion is everything that I'm talking about. We need to assess the patient and teach them about cardiovascular disease, cerebrovascular disease, stroke, ischemic problems, right? And so go to your, So for diet modification is really how to watch out with sugars. Number one, sugars. If they can get rid of that soda pop, stop it, right? Yes, cholesterol and saturated is a problem, but it's not the saturated fat as much as the adipose tissue that is building up in the fat. So it's the fat in the adipose tissue. And that for the most part happens because of lack of exercise and processed foods and high sugar foods. So there you have it. Refined foods, refined sugars are really a big no-no. We got to teach them to avoid injury to the extremity, and we have to encourage them to have really to try to decrease the stress, right? And yeah, of course, if they have histories in the family of cardiac or diabetes or vascular problem, then yeah, that's a risk. But remember, that's a small percentage as opposed to what we can tell them they can do for themselves in a day-to-day lifestyle. So in acute care, we got to frequently monitor after surgery, color, temperature, motion, sensation, pulses. We have to monitor their cap refill, right? Hopefully it's below 3. If it's above 3, then obviously there's a perfusion problem. And so at the beginning, it'll probably be every 15 minutes, you're going to do a set of vitals and a series of checks to bilateral extremities. Then it might be hourly, and we're going to look for that color, that temperature, that cap refill, that sensation, that movement. Are they able to move? Don't forget sensation and movement. If they're able to wiggle their toes just a little bit after surgery and an hour later they're not able to move their toes, that is a sign that it's getting worse. If they're able to move their toes right after surgery and an hour later, and an hour later, they are now able to move the foot and the toes. There's an improvement. Then hopefully we'll be able to get them to lift the leg up off the bed. So we want to see a gradual improvement. That's why we're doing all of these assessments, okay? Make sure that circulatory assessment is happening. We have to monitor complications. And what complications can you think happen? Charlie? No. What complications do you think might happen with this type of surgery? Bleeding, hematoma, the thrombus formation, maybe even a pulmonary embolization, compartment syndrome. If they're having any type of surgery in their lower extremity, you guys really need to be able to work with compartment syndrome. Most of you should have already had a simulation with compartment syndrome and understand how important it is and how big a risk it is. So we need to monitor for those complications. We also, remember, monitor for those pulses and pallor, cyanosis. We will be doing their ankle brachial index. We will be looking for numbness or tingling, cold extremity could be a blockage, right, of the graft. If they had a graft or a stent and it starts getting cold, that's a big no-no too. We need to notify the surgeon, let them know it's a big problem, right? Try to discourage them to have prolonged sitting because the leg dependency can cause pain and edema ultimately. So it's a tricky balance there, and increase ultimately it'll increase their DVT risk, right? And so we need to be careful with that. If edema does develop, then position the patient supine, elevate the legs above the heart for a while. Walking even short distances, even if it creates pain, we know, but it's going to be desirable. And then if they need to use a walker, then just make sure that you work, especially in the frail elderly patients, right? Ambulatory care, this is when they're getting ready to be sent to a outpatient, or they're on the floor getting ready to be discharged. We really want to talk about, again, their risk factors, and that's tobacco. And if they had a graft or a stent, then they may need to have further follow-up with the surgeon. They may need to be put on some type of antiplatelet over time. Aspirin or Plavix is recommended, as we talked about. And then explain that, exercise overall is going to decrease their cardiovascular risk factor. It's going to help their hypertension, and their hyperlipidemia, and their obesity, and their glucose levels. Charlie, no. And then with patients that have ulcers or PAD, really teaching about really having meticulous foot care is extremely important, especially in diabetic patients. And sometimes they may need to even go into their podiatrist to get nail cut properly. Daily inspection of the feet. Make sure they look at their shoes before they put their feet in, because they may not have enough sensation on their feet to know that they stepped on a glass or on a tick on something that might create a small bleeding. And remember, once they have that open skin, the risk for infection and wound, it'll grow and grow and grow. And sometimes in a lot of patients, that leads to the amputation. Show patients how to check for their skin temperature, capillary refill. Show them how to check for their pulses, right? Stress when you talk to them, tell them that they need to report any changes in the findings of their pulses, or the development of their ulceration, or if it's getting more and more inflamed, or make sure they get a thermometer, right? And make sure that they check for their temperature as well, in case infection starts to kick in. So how do we evaluate? Well, really, the way we evaluate is that it's the same nursing care plans that we have to do. They're at risk for tissue perfusion. Well, if tissue perfusion is improving, our evaluation is to check that the pulses are coming back, that if it was cold and clammy, that it's now warmth is coming back, that they're able now to move or ambulate or get up. They're able to do more than before, increased activity tolerance. Their pain management is improving. And again, we always talk about knowledge of the disease and treatment plan, but we completely forget and sidestep that really that one last thing at the end, the knowledge of the disease, is there's tremendous amount of information out there that we can talk to the patients. And part of it is really letting them know that they're going to have to make a drastic, radical change in their life. They could go one step at a time. And, if in the first 6 months they can quit smoking, great. Or if they quit that high fructose corn syrup pop, that Dr. Pepper or Coca-Cola, Pepsi Cola, great, wonderful. That's a great step. But then there's a lot more than that. We need to talk to them about phytochemicals, nutrients, about vitamin C, E, D, A. We need to talk to them about selenium. We need to talk to them about what they can do on their own in terms of getting out and ambulating and putting their feet at least for 45 minutes on the ground to do grounding, right? These are all things that, remember, when we talk about, Florence Nightingale and her use of light and oxygenation and sunlight, with what we have and the knowledge we have out there and available, as nurses, these are all non-prescription things that we can talk to our patients. We are not saying that vitamin C cures PAD. We are not saying that vitamin E and D and A and selenium and sulfur are the cure for PAD. 3D. What we're saying is that at the cellular level, eating proper foods, if we can get them through proper nutrition and diet and proper foods, superfoods, eat goji berries, eat the sulfur-rich foods, eat foods that have strong phytonutrients, eat foods that are color. These are the conversations that we need to, so you can see how you guys are going to be getting this for 2 years, and you might have 20 minutes to talk to your patient when you discharge them, but what we really need to inculcate in our patients is that they need to make a radical change and start to get out there and hike and start to get out there and de-stress, and if they need to change their position within their job or their employer, if at all possible, then so be it, right? So that last point really is there's a lot of information there. Further evaluation, just get them to walk, ambulate, remember, slow, to assess for what their baseline is, try to increase their activity tolerance. And then they need to verbalize what their therapeutic regime is. They need to verbalize they're not going to smoke if they can, right? If they need to talk about what they're going to do in terms of their diet, right? We need to talk to them about, check their homocysteine. We talked about how to reduce their homocysteine naturally, right? And then what knowledge of disease. That means we need to tell them that it's an atherosclerotic plaque buildup, and that we need to be consuming the proper things that are going to help their arteries get stronger. Yes, people, that's very important. That's part of the knowledge of the disease. It is part of our role as nurses to talk to them about the knowledge of the disease and the treatment plan and to reduce risk factors. You can't reduce their gender and change their gender. Well, there may be people who can go into a transgender and change, but from a medical perspective, you can't change their age, for example. As they age, but what we can change is if their homocysteine is elevated. If they are eating a very pro-inflammatory diet, the standard American diet every day, we can change that. Pizza, soda pop, fried chicken, hamburgers on a daily basis are a big no-no. So those are all risk factors that we can reduce, and we can start to introduce everything that we've been talking about in almost every lecture that I give you. If you don't see how important it is, slowly I hope to ingrain in you that there's a lot that can be done, and then obviously proper ulcer and foot care. So with critical limb ischemia, here we're talking a little bit more about hospital type care. There's a lot of things, right? Really what you need to understand with critical limb ischemia is it's basically chronic ischemic pain that happens when it's resting and for more than 2 weeks with arterial leg ulcers and or gangrene of the legs due to the peripheral arterial disease. And optimal therapy for these patients with critical limb ischemia is to try to revascularize it, usually doing a bypass surgery. And I'll show you that a photo that I put in here actually shortly, I believe. And if that's not, if a lot of these things are not feasible, we can do an angioplasty or PTA, percutaneous lumen, opening up the lumen, transluminal. Percutaneous transluminal across the lumen. Remember, PAD is all about atherosclerosis, so we want to go through the lumen, and it's the lumen that is being closed from the plaque buildup. So it's all about plaque. In fact, if you have an endarterectomy is pulling out a big fat lump of fat tissue up in the carotid area. So no different from the peripheral, right? Just same thing, plaque buildup. So patients who have critical limb ischemia, who may not end up being able to get that transluminal angioplasty, could be treated with IV medications, and ultimately they may end up having amputation if it's really that bad. Now angiogenesis is a word. There was a doctor. What was his name? Dr. Lee, William Lee, L.I. He's on YouTube. He has a TED Talk, and he talks about how to starve a cancer. If you guys haven't seen Dr. Lee's talk, it's an old talk, but it's still worth watching. It's about less than 20 minutes. He talks about angiogenesis. And what cancer does, for example, is they're able to create new blood vessels, that's the word angiogenesis, to draw the nutrients in the blood and the oxygenation to itself so that the cancer, can grow more. And so Dr. William Lee, L.I., on TED Talk, How to Starve Cancer, talks about, and he's out of UCSF, I believe. He has a team of people. And one of the things he found out, if you haven't seen it, go watch it. Please watch Dr. Lee, L.I. how to starve a cancer. Vitamin E alone was better than a lot of the other. Green tea was one of the most profound things to create a proper healing for a lot of the patients that he was seeing. So angiogenesis is, and so for patients who have PAD, they use growth factor or stem cell therapy to try to stimulate blood or vessel growth in the area. But people, if we can prevent that plaque buildup from the start, by just telling them that watching all those football games with all that fried chicken and hamburger is just not a good idea. If you treat yourself once a month, maybe okay, right? It's not like you have to quit it always, but if that's your staple food, then maybe we do need to do a lot more aggressive therapies and stimulate blood vessel growth. But they're at least stimulating blood vessel growth through angiogenesis is better than having to open the leg with a bypass, for example. So with, again, considering critical limb ischemia, we want to carefully inspect the area, cleanse it, lubricate it, prevent cracking of the skin. Remember, it's going to get shiny and taut. So proper skin care is important. But if ulceration does happen, we got to keep the foot clean and dry. Cover the ulcers with the dry, not wet, nothing wet with these people. Sterile dressing to try to maintain that cleanliness and change if it gets dirty. If they have deep ulcers, we can start treating them with a lot of different wound cares. Talk to your wound nurse on the hospital. They have tremendous knowledge. They're a great resource. Doesn't mean they should be doing the work for you, but we can learn and help them out, and they can teach us when we're with our patients. But really, healing is really going to be unlikely unless we get that increased blood flow. And so sometimes in patients, they may need to have antibiotics if they get infection, but we really want to encourage the patient to really try to get footwear that is protective, that is soft, that has room in it, that's not tight. Wearing tight pants and tight jeans and tight exercise is usually not a good idea. And really an important thing for these patients is to try to avoid extremes of heat and cold, because heat and cold is going to create more movement of that artery. And remember, the artery dilates and vasoconstricts and dilates and vasoconstricts. If they're diabetic, it's going to be thick and plaqued and build up with the sugar, and their A1C is elevated. If they smoke, it's the vessel is going to be really tiny because they have nicotine in their system. So if you now are, they're already having very weak arterial lining, endothelial lining, endothelial damage, that if they go into a heat room in a cold and a heat in a cold, then they're going to be at more risk for developing further complications of that endothelial lining, as you can imagine. So radiation, interventional radiology, AIR, which is a big modern, relatively modern procedural, it's great. These procedures, they happen usually in a cath lab rather than an operating room. They're very well controlled. And they can help decrease a lot of the blockages, and we just need to understand that there's pre and post nursing care that we have to watch out for a lot of these things. But intervention radiology is a viable way to approach. And so a couple of them, as I talked to you earlier, percutaneous transluminal angioplasty. Transluminal, remember, PAD, peripheral artery disease, is really nothing but the same as cardiovascular disease, the same as coronary artery disease, and it's a problem of the lumen because there's a plaque buildup. So we're going in there to try to help remove that plaque. And how do we remove that plaque? Well, if there's an obstruction, the balloon is going to be inflated. It's going to help somehow that intimal lining to open up. We can place a stent. Once that stent is placed, it opens it up. And I thought I had a picture here that showed that. And then it helps, the stents will help. And some of the stents nowadays, they have drugs in a drug agent added to it to reduce the likelihood of it re-happening. The problem is that we know that with PAD, it can happen anywhere in your body. It can happen in your carotid area. It can happen in your coronary artery. It can happen in your femoral artery. It can happen in your popliteal artery. So really, this is really a very, very, very much of a downstream therapy to treat it. They're just trying to open it up, get the blood flow to go through, which is a great thing. It's a wonderful thing. I'm not poo-pooing this. Then, especially with critical limb ischemia, we want to prevent amputation. If this can happen, great. But we need to tell them that plaque is still going to probably still build up, and it may not build up where that stent is because it has a drug-eluting agent added to it, but it might happen in 1,000 other areas in the body. And so, yes, PTAs are really good. Atherectomy is just removing that plaque, right? It's cutting in. So endarterectomy, God, and I thought I had a, hopefully I did, I think I did add an endarterectomy. So when you hear ectomy, it just means we're cutting it and we're removing it. And atherectomy is just going in and they could use a laser as well. So there's very modern forms of doing an atherectomy. And basically all this is, people, is if we know that peripheral arterial disease, the underlying reaction that the body has to a very weak endothelial damage due to lack of L-arginine and a lack of nitric oxide, which, by the way, eating a lot of beets is really good to help with L-arginine and nitric oxide. If that endothelial tissue, that endothelial lining of the cell is very weak, and microvascular cuts start to perform and the body naturally reacts to it by building plaque, going in and doing an atherectomy is going to help remove all the plaque and can definitely save lives. It's a wonderful thing, right? But if we don't talk to our patients when they go out and tell them why we had to remove that plaque and what they can do to prevent building it up in the first place, well, we're being negligent as nurses. Further intervention radiology is cryoplasty, and it's a balloon filled with nitrous oxide that changes from liquid to gas, and it enters the balloon, and the expansion of the gas results in a cooling. The temperature limits restenosis by basically reducing smooth muscle cell activity. But really, proper diet over long periods of time can help reduce smooth muscle cell activity and improve the mitochondrial productivity of the ATP and reduce the ROS, or the reactive oxygen species, and reduce the inflammation to the area by eating superfoods, goji berries, and certain things like that. So there is room for cryoplasty. There is room for PTAs and atherosclerosis, and even doing endarterectomies. If we can pull that plaque out of there, great. Together with pulling that plaque, we need to educate our patients that there is a lot that they can be doing on their own. I did put into so if intervention radiology, PTA, cryoplasty, or balloon opening or stenting of the area to allow the revascularization to just let blood get back to the toe that is slowly disappearing. After all, Charlie, the blood is not getting there, so the pulses are starting to disappear. It's getting cold and clammy, so they go in. Well, if none of the ones that I talked about previously work, surgery may be a possible next step. And what we would do is we'd do similar to doing a coronary artery bypass graft for somebody who had a lot of problems up in the heart. We would do a peripheral artery bypass surgery. And it would be done, we'd basically go in and they would find a local vein of the person to end up bypassing, which bypass just means carrying blood around, right? So if we can do it with a stent, do it with a balloon, do it with the cryoplasty, do it with the angiogenesis, do it with whatever we can. If none of that works or they're not a candidate, then we would go in and find a vein of theirs to just simply bypass. Bypass simply means carrying the blood around the lesion, right? And so synthetic grafts are usually used for long bypasses. They can do it in the axillary or femoral, but when a person's own vein may not be available, there are human umbilical veins or certain types of sequential native veins or synthetic grafts, that can be utilized to bypass that, right? And so all this is doing is just saying, okay, well, we have plaque buildup there. How are we going to get that? So it's a very invasive therapy that, again, can help patients, but hopefully we can get them eventually down the line to prevent them from getting there in the first place. And in terms of bypass graft, this image just shows you the one on the left is femoral popliteal bypass graft. And it's going around an occluded femoral artery. And then the B, or the one on the right, is a femoral posterior, so behind tibial bypass graft around the area that is occluded, which is I think it's a femoral popliteal, and even it's bypassing 3 areas there. Look, see how that bypass graft, synthetic graft, goes from the top all the way to the bottom. So it's bypassing the femoral, it's bypassing the popliteal, and the proximal tibial artery. It's getting down to that area. So that's just bypassing it. That's basically a surgery. Other surgical therapies that we can do, and right there at the bottom is the end of the end game right there. That's a leg that's lying on a table. And yes, they're so common, we call them AKA, above knee amputation, or BKA, below knee amputation. And it just happens because patients have risk factors of cardiovascular disease, which put, coronary artery disease, plaque buildup, and Dean Ornish in UCSF has completely demonstrated, and in fact, by the way, people, paid for now by Medicare. People, insurance companies are following this Medicare. Dr. Dean Ornish, with giving patients over 9 months a rabbit diet, eating vegetables day in and day out, day in and day out, day in and day out in a very controlled environment, completely reversed the plaque buildup of people that were scheduled to have coronary artery bypass grafts. So there are ways now. I think the Medicare calls what Dr. Dean Ornish did intensive cardiac rehabilitation, but it's basically, yes, it goes through certain exercises and they work with the patients, but it's diet. It's diet, people. The image on the right basically shows a carotid artery. See the head of the patient, and they're just pulling out a piece of plaque. And you should see, I've seen plaque come out of arteries. It's not even a joke. They're huge. Just go to Google Images and put in carotid plaque arteries, and you'll see this big, long things that you just pull it right out of there, and reperfusion of blood happens. So the patch graft angioplasty is basically, again, doing what? We'll go figure. Opening of the artery, removing of the plaque, sewing or a patch to the opening to widen the lumen. So they put a plaque there to keep the lumen bigger. And you guys probably won't get, I think chapter 62 will talk about amputation, but yes, it's a downstream therapy. So I think we're almost done. Just a few more slides here. See if you guys can look at this question. I'm going to take a quick sip of water here. Charlie, see if you can come up with the answer. All right, so you have a patient that has PAD, peripheral arterial disease, and they're telling you that he or she is marked with peripheral neuropathy. So when you hear peripheral neuropathy, you should probably think what? Lack of sensation, they may not be able to feel. So what's an appropriate nursing diagnosis for a patient that has peripheral neuropathy? Remember, peripheral neuropathy is caused by what? Always go back to try to understand the pathophysiology. If peripheral neuropathy is caused by a diminished perfusion, that's the whole everything we've been talking about with our cardiovascular lecture is lack of perfusion. So if there's not enough perfusion, oxygen, nutrients to the neuron, that neuron is going to have there's going to be a loss of both pressure and deep pain sensation, and so they're not going to be able to feel. So the patient ultimately is not going to be able to notice extremity injury. And so really think that neuropathy increases the risk for the patient to end up getting traumatic injury. So you can guess that it's going to be a risk for injury related to decreased sensation. Absolutely. I'm going to take another sip of my water. Boy, my throat. Go ahead and read this really quickly. So the nurse is going to teach a patient, again, has PAD, peripheral arterial disease. The nurse determines that further teaching is going to be needed. Further teaching, always be careful with that. So three of them are going to be right. And when it says further teaching, it's telling us if they say one of these, A, B, C, or D, they're wrong. They need further teaching. Determines that further teaching is needed if the patient makes which statement. So we're going to be looking at which one of these is wrong, that we need to tell them that no, that's not correct. Clearly the bottom one, D, right? I can smoking cessation is going to be important. And if initially to get them there, they need to use nicotine gum in a support group, by all means, absolutely. So that's good. That's they don't need any further teaching there. They're obviously talking about wanting to quit smoking, and boy, if they can do that alone, they're already improving. Um, and so I will examine my feet every day for any sores or red areas. Why would they not want to do that if they already have peripheral arterial disease? They need to do that. So that's good, right? Then we have A or B. So it's either I should not use heating pads to warm my feet, or I should cut back on my walks if it causes pain. In this case, it's just saying they have peripheral arterial disease. They're not necessarily saying that they have diabetic neuropathy or peripheral neuropathy. So using heat pads could be good. We want to try to warm their feet. We just want to make sure that they're not hot pads, and that if they do, you have peripheral neuropathy, which is not the case in this answer, this question here. Heat pads, if too hot and they don't have sensation, one, they don't want to leave it on too long, like ice, for example, same thing. But in their case, we want to try to revasculate or bring blood down there. So warming is a good thing. We just need to be very careful with heat pads. So it's okay for them to use heat pads. So we're left with one. I should cut back on my walks if it causes pain in my legs. And what we really need to, if you haven't gotten it already, we should be teaching our patients to actually exercise to the point of discomfort, tell them to stop and rest, and then resume walking until the discomfort recurs. What we don't want to tell them is that, no, you should not be doing exercise. Absolutely not. So the patient needs further teaching if they say, I should cut back on my walks. No, they should keep walking, just stop when the pain happens, rest, and then go back at it, okay? All right, so let's go to the next one. And then I have just a couple more slides that I threw in. There's something called EDTA chelation therapy, ethylene diamine tetracyclic acid. And basically this is a prescription medication. It can be given in injection, IV, can be given intramuscularly. It's what we call chelation therapy. Chelation is where it's a treatment. It's used in conventional medicine. There's a lot of people out there that still poo-poo it, but the science is slowly starting to come around that are saying that oral or IV form of chelation therapy, and it's removing heavy metals, it's removing mercury, it's from the blood, it's removing lead, it's removing a few other things, and it helps to chelate. It's basically a synthetic amino acid, and we can use it for lead poisoning, we use it for brain damage, we use it for people who have really high levels of calcium, hypercalcinemia. Right? You can give them an EDTA therapy to try to bring that down, right? It can help patients remove platinum, thorium, uranium, strontium. It can remove copper in patients that have a genetic buildup called Wilson's disease. They have too much copper, so copper can be very toxic, right? So it's been utilized in many situations, and there's even a book that says bypass surgery that talks about how in many cases, using simple combinations of EDTA with magnesium, vitamin C, and B are very positive. And so it is an alternative to a lot of the angioplasty and even bypass surgeries. It is also used, by the way, EDTA or chelation therapy is also used intravenously for heart and blood vessel conditions. It's used for irregular heartbeat. It's due to maybe exposure to chemicals, even exposure to cardiac glycosides, which are drugs and things that are given to the patient by the medical system. Sometimes they need this to reverse. It's also given for hardening of the arteries, people. What's another word of hardening of the arteries? Hardening of the arteries. Atherosclerosis. Atherosclerosis is not only the plaque buildup, but it's hardening. It's loss of elasticity of the arteries. So helping the body remove a lot of these things. And if you use makeup and eat and live in the day-to-day world that we live in, there's hardly any of us who don't have toxins in our system. And this is proven to be a very good thing. Patients with angina, chest pain, high blood pressure, high cholesterol, risks of stroke, blood circulation problems are showing tremendous results with this therapy. These are just a few of the toxins or metal buildup. So aluminium alone, right? Where do we get it? Cookware, tinfoil, antacids, antiperspirants, baking soda, baking powder, buffered aspirin has it, Canned acidic foods has aluminum. Food additives, lipstick, people, your lipstick may have aluminum in it. Medications and drugs, a lot of the anti-diarrheal agents, some of the hemorrhoidal agents, the vaginal, the douches, the cleanses, they are full of aluminium or have aluminium. Even processed cheese or softened water, tap water. So where does aluminium attack? Aluminium attacks bones, brain, kidneys, and stomach, and you could end up having symptoms like colic or dementia, esophagitis, gastroenteritis, kidney damage, liver problems or dysfunction, loss of appetite, loss of balance, muscle pain, psychosis, shortness of breath, weakness, all because of aluminium. Arsenic. So where do you get arsenic? You get it in air pollution, antibiotics given to commercial livestock. They have it. So if you're eating foods that have antibiotics, you're probably getting arsenic into your butt, into your tissues. Certain marine plants have it. Chemical processing, coal-fired power plants, defoliants, drinking water, drying agents for cotton, fish, herbicides, insecticides, meats, usually meats that come from commercially raised poultry and cattle. So buy local, people, because if not, you're probably getting arsenic in it. Metal oil smelting, pesticides, seafood, things like fish, mussels, oysters, specialty glass. People who work with glass are going to be high risk at it, and wood preservatives, wood, people who work in carpentries. So where does arsenic target? Most organs in the body, especially the GI, the lungs, and the skin. A lot of lung cancers, right? So they'll, EDTA doesn't work, but we're being exposed to so many things. So what signs and symptoms will people with arsenic? Abdominal pain, burning of the mouth and throat, especially the lung and the skin, coma, going into a coma, diarrhea, nausea, neuritis, peripheral vascular problems. Let me repeat that. Peripheral vascular problems. Let me repeat that. Arsenic buildup in your body can lead to peripheral vascular problems, but most doctors aren't even looking out for these things. They can lead to skin lesions and vascular collapse if you have that. Cadmium, air pollution, art supplies, bone meal, cigarettes, smoke, food, coffee, fruits, grains, vegetables grown in soils that are full of cadmium can lead to that. Meats, like a lot of the kidneys, liver, poultry, refined foods, many of them are full of cadmium. Freshwater fish, fungicides, highway dusts, incinerators, mining, nickel cadmium batteries. Yeah, those nice electric batteries, Prius and things, they have nickel cadmium. Now, the likelihood of being exposed is very light, very low, but still they're there. But people who work in the factories are at high risk, right? Oxide dusts, paints, phosphate fertilizers, power plants, seafoods, for example, that have cadmium, crab, flounder, mussel, oyster, scallops, sewage sludge, softened water, smelting pans, tobacco smoke, welding fumes. But where does cadmium attack? It attacks the tissues, mainly your appetite, your pain centers. It attacks the brain, heart, blood vessels. So I say it again, blood vessels. So cadmium attacks the blood vessels, kidneys, and lungs. And you're going to get anemia, dry and scaly skin. You may end up showing signs and symptoms of emphysema, fatigue, hair loss, heart disease, depressed immune system, hypertension, joint pain, kidney stones, liver dysfunction, damage, loss of appetite, loss of sense of smell, lung cancer, pain in the back and the legs, and yellow teeth, all because of cadmium. Then you have lead. So lead, air pollution, ammunition, bathtubs, cast iron, porcelain, steel, batteries, canned foods, ceramics, chemical fertilizers, cosmetics has a lot of lead in it, dust, foods grown around industrial areas, gasoline, hair dyes, and hair rinses, full of lead, leaded glasses, newsprint, colored advertisement, paints, pesticides, pewter, pottery, rubber toys, your children, soft coal, soil, solder, tap water, tobacco, smoke, vinyl, all. Where does lead target? The bones, brain, heart, kidneys, liver, nervous system, and the pancreas. And it's going to show up, again, abdominal pain, just a general, hey, I got abdominal pain, anemia, anorexia, anxiety, bone pain, brain damage, confusion, constipation, convulsion, dizziness, drowsiness, fatigue, headache, hypertension, inability to concentrate, ingestion, irritability, loss of appetite, loss of muscle coordination, memory difficulties, miscarriage, muscle pain, pallor, tremors, vomiting, and weakness, all from lead. Mercury, well, we know that. Again, air pollution. Our air is full of it. Batteries, cosmetics. We all know dental amalgam, the teeth, right? Teeth fill-ins. If you have that, go to a dentist. You can get your mercury removed. I did. It just has to be done by a trained and certified dental clinic that can do it. Electrical devices and relays, explosives. Some foods and grains are full of mercury. Fungicides, fluorescent lights, freshwater fish, especially the large bass, pike and trout, right, have a lot of mercury. Insecticides, mining, paints, pesticides, petroleum products, saltwater fish, again, large halibut, shrimp, snapper, swordfish, shellfish. Tap water sometimes can do it, and it will attack your appetite. Pain centers, again, brain, cell, membranes, kidneys, nervous system, nickel. You get the point. I'm not going to even read. If you're interested, I'll shoot out the nickel to you. That's in a nutshell. So last slide, people. This is the last slide. Physicians that have been administrating this for many, many years, since starting in 1952, they started with lead toxicity, and what they found out is they observed that patients who had atherosclerosis, so I repeat that, patients who had atherosclerosis, fatty plaque buildup, and hardening, lack of flexibility of the arterial wall, hardening of the arteries, they end up experience reductions in both the conditions. Not only did the lead go, but so did the artery of the lining start to improve. So IV EDTA chelation has been used to treat cardiovascular disease. San Francisco has about a dozen of trained doctors who do it. Sacramento has about 6 or 7 about them. So you have to go to somebody who's certified and knows what they're doing. But there's almost 2,000. By this point, there's probably more than 2,000 scientific journals that have been published on the use of EDTA and IV chelation. And in the past 30 years, hundreds of thousands of patients have received this therapy as delivered by more than 1,000 physicians. So you could almost calculate that well over 3 million IV infusions have happened, and the success rate in increasing blood circulation alone, let's not talk about other benefits, but blood circulation alone is 82%, provided that they got enough chelation therapies done, not just 1 or 2, but multiple, to get what you have in your body out of the body. Now, Dr. Gary Gordon, who is, they call him the father of chelation therapy, and he's now trying to get all the peer reviews together, at least in the state of Arizona, to get it recognized. Obviously, there's a big fight to get chelation therapy out as an approved, and you can imagine why, right? There's a lot of money in hospitals to be made by stents and coronary artery bypass graft. Whether it's intentional or not, we don't know, but we do know that EDTA chelation therapy works, and a lot of doctors are out there that are already swearing by it, and they're using it in their clinics, and it's a lot cheaper. And so Dr. Gary Gordon is he's written quite a few books, and he's on YouTube. If you have any time and you want to learn more about the wonders of EDTA, listen to Dr. Gary Gordon on YouTube. He'll teach you quite a lot. So we're done. Hopefully you got a good amount of it. So just remember what PAD is, what's the underlying problem, remember what we need to do and what we need to know, and remember the difference between arterial and venous, because you're going to have to know that. And hope you have a good rest of the evening.